Hey everyone, welcome back to all my listeners. Now, I hope you're all having a great day so far, and if it's your first time finding me, thanks so much and welcome. Welcome to episode 15 of my 5th season. Today is Wednesday, April 13th, 2022. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. Now, all right, you guys, I think you remember I told you all that I spent the last week down in Florida working on site with a variety of providers, from endocrinology specialists to pulmonary and sleep specialists and the like. So I was busy for the entire work week. Barely got to enjoy any time at the beach or see the sun or the palm trees or some oranges, whatever. But I'm back now in cold and rainy, and small snowflakes are still flying in Chicagoland area as I record this episode, but there are tulips that are bursting through the soil in my yard, so hopefully I'll see some tulips blooming here in the month of May. But anyway, so that's enough about me. I hope you guys all enjoyed watching the Masters in Augusta, Georgia on TV, or if you had tickets, it was amazing. I always like to root for the underdog, so I'm glad an underdog took the green jacket this year. Anyway, so that's enough about my fun. Let's get to the podcast today. I've got plenty to unpack, right? So in my compliance tip, I'm going to be diving into a few important documentation tips that I love to give episode after episode. And this one really nails it home for me because a Medicare contractor, in fact, also agrees to these types of details that I've been providing from episode to episode over season 1, season 2, season 3, season 4, and definitely in season 5. So I just want to highlight a few of these questions that folks have asked and NGS has answered. So we'll get into that in my trusty tip. But today is also the second Wednesday of the month, right, where I go ahead and share my very newsworthy OIG Work Plan update for the month of March. And I go ahead and round out today's episode with the remarkable quote on clarity and focus from Mindy Kaling. If you've checked me out on LinkedIn, you guys know I'm all about compliance and protecting our physicians and our valued healthcare professionals when it comes to the business of medicine. I hope this week with me brings you enough to take back to your organizations, to want to dive in deeper, to use my tips and best practices to ensure success. I hope this podcast will help you boost the quality of documentation capture and improve your coding accuracy as you help your providers paint the medical picture. If you like what you're hearing, please go ahead and hit that subscribe button now so you don't miss another episode. Please write in a review and kindly drop me a 5-star rating on Apple Podcasts or wherever you listen to my podcast. I'd really love your support. And as always, a friendly disclaimer. Remember, I'm bringing you the news, current healthcare industry news, my compliance tips and recommendations based on my over 10 years of experience in front office, back end, coding, and billing for multi-specialty physicians, compliance, and auditing for both E&M and surgical operative reports. These are my opinions alone and are not to be construed as legal advice. So let's get into Newsworthy. I wanted to go over the 7 new March 2022 updates made to the OIG Work Plan. Now, the first is titled Audit of States Child Support Administrative Costs. Now, this is an audit stemming from the Office of Audit Services. The Child Support Enforcement Program, established in 1975 under Title 4D of the Social Security Act, functions as a federal, state, and local partnership to collect child support payments from non-custodial parents for distribution to custodial parents. Now, within the Department of Health and Human Services, Administration for Children and Families, the Office of Child Support Enforcement provides federal oversight of this program. In most states, a single state agency performs the day-to-day operations, but in others, counties operate the program and states administer it. Program responsibilities include locating non-custodial parents, those who are not the primary caregivers or do not have custody or control, and then establishing paternity and support orders and collecting and distributing child support payments. Now, costs to carry out these responsibilities are administrative and uncapped, so the federal share of the program increases as states spend more on the program administration. Based on a risk assessment, the OIG will select states for review to determine whether program administrative costs claimed were allowable and in accordance with federal and state requirements. This final report is expected in fiscal year 2023. Now, the second OIG Work Plan update for March 2022 is titled 2021 Performance Data for the Senior Medicare Patrol Projects. This report is coming from the Office of Evaluation and Inspections. Now, this memorandum report presents performance data for the Senior Medicare Patrol Projects, which receive grants from the Administration for Community Living to recruit and train retired professionals and other senior citizens to recognize and report instances or patterns of healthcare fraud. Now, the OIG has collected these performance data since 1997. This final report is expected in fiscal year 2022. Now, the third OIG Work Plan update for March 2022 is titled Achieved Savings Rebate Program Offset of Rebates on CMS-64. Now, this analysis is stemming from the Office of Audit Services. The Social Security Act Section 1115 gives CMS authority to approve experimental, pilot, or demonstration projects that it considers likely to assist in promoting the objectives of the Medicaid program. States may then use CMS-approved waivers to have managed care organizations, or MCOs, provide care to Medicaid beneficiaries. Under these arrangements, states can make capitation payments to the MCOs in return for the MCOs providing the patient care for the Medicaid beneficiaries. Some states place limitations on MCOs' earnings, for example, limiting the profits they may earn or requiring a certain percentage of their revenues to be spent on medical expenses. States with such limitations may require the MCOs to return a portion of the capitation payments when the MCOs exceed those limitations. Now, according to the Social Security Act, Section 1903D-3A, states are required to refund to the federal government the federal share of any amounts recovered during any fiscal quarter. Additionally, in 45 CFR Section 75.406A requires recipients of federal awards, and these also include state Medicaid agencies, to credit to the federal award the federal share of reduction of expenditure types of transactions, such as rebates, purchase discounts, or allowances when those transactions relate to allowable costs. For selected states, the OIG will determine whether the states properly offset against CMS-64 expenditures refunds of capitation payments received from MCOs. This final report is expected in fiscal year 2023. Now, the fourth OIG Work Plan update for March 2022 is titled Medicaid Estate Recovery Program. This review is coming from the Office of Audit Services. Several states have not implemented all the requirements of their Medicaid estate recovery programs. Therefore, they might be running the programs ineffectively and not recovering certain long-term care costs due from the applicable estates of deceased Medicaid recipients. The OIG will determine whether state agencies under their Medicaid estate recovery programs did these four things. Number one, had policies and procedures to comply with federal and state requirements. Number two, attempted to recover the applicable reimbursement costs for certain long-term care. Number three, accurately reported Medicaid estate recovery amounts associated with certain long-term care services on the CMS-64. And finally, fourth, identified the costs incurred to recover from the estates. This final report is expected in fiscal year 2023. Now, the fifth OIG Work Plan update for March 2022 is titled Audit of the Department of Health and Human Services Progress Toward Compliance with the Geospatial Data Act of 2018. This analysis will be conducted by the Office of Audit Services. Now, the President signed into law the Geospatial Data Act of 2018, the GDA, as policy number 115-254 on October 5th, 2018. Now, the GDA fosters efficient management of geospatial data, technologies, and infrastructure through enhanced coordination among federal, state, local, and tribal governments, the private sector, and academia. The GDA establishes responsibilities and reporting requirements for covered agencies. Additionally, the GDA requires the Inspector General of each executive department or the senior ethics official of each executive department without an Inspector General to submit to Congress not less than once every 2 years an audit of the collection, production, acquisition, maintenance, distribution, use, and preservation of geospatial data by federal agencies. The purpose of this audit is to determine the Department of Health and Human Services progress towards compliance with the GDA. Now, this final report is expected in fiscal year 2023. The sixth OIG Work Plan update for March 2022 is titled COVID-19 Vaccination Status of Nursing Home Staff. This audit is being conducted by the Office of Audit Services. Residents of long-term care facilities or nursing homes have been severely impacted by COVID-19 and are disproportionately represented in the number of COVID-19 related deaths in the United States. Data reported by nursing homes to the Centers for Disease Control and Prevention's National Healthcare Safety Network identified that COVID-19 infections among nursing home residents were higher in nursing homes with lower vaccination coverage among staff. The data also indicates that while nursing homes have made significant progress in vaccinating their residents, approximately 1 in 5 nursing home staff were not vaccinated as of the end of 2021. Now, CMS amended federal regulations at 42 CFR section 483.80 to require that nursing home staff be fully vaccinated against COVID-19. The regulations allow nursing homes to grant staff exemptions from the vaccination requirements based on federal law. For example, that could be for specific medical and religious reasons. Now, the regulations, among other things, also require nursing homes to track and securely document the vaccination status of staff, exemptions requested, and exemptions granted. The effective date of the regulations will vary by state, but all states must be in compliance by March 21st, 2022. Through a series of audits, the OIG will determine whether nursing homes nationwide are in compliance with the regulations and identify the COVID-19 vaccination status of their staff members. Now, this final report is expected in fiscal year 2022. Now, the seventh and final OIG Work Plan update for March 2022 is titled Medicare Fraud Control Unit Data Mining, Outcomes, Challenges, and Beneficial Practices. This analysis is being conducted by the Office of Evaluation and Inspections. Now, Medicaid fraud control units, the MFUCUs, investigate and prosecute Medicaid healthcare fraud and patient abuse or neglect. Since the year 2013, MFUCUs have had the option to apply to the OIG for approval to use data mining. This program integrity method could improve MFUCU's ability to identify potential fraud and patient abuse or neglect cases and more effectively target their resources to significant areas of vulnerability. The OIG will examine the MFUCU's experiences in implementing and using data mining, including any challenges and specific successes, and they will also evaluate the outcomes of the MFUCU's activities. This final report is expected in fiscal year 2022. Wow, right? So those 7 OIG Work Plan updates for the month of March 2022 are pretty detailed, right? And the OIG continues to work so hard in all of their evaluations, inspections, and audit reports that will be released later in 2022 and in 2023. So again, we're still in a public health emergency status as of the recording of this episode. So, irrespective, they are working so hard. Now, of course, I understand this audit on the COVID 19 and the nursing homes and the vaccination of their staff. It's important to see if nursing homes across the nation are following these recent regulations state by state. So, in my opinion, I always pass this critical information on to my providers who need it to review their coding and their billing practices or their overarching compliance programs. I think these reports with findings are always most interesting and informative, and I always look forward to analyzing them in the years ahead. It's also important for my listeners to pay attention to these monthly OIG Work Plan updates to see how they may impact you, your provider, or your health system. And again, stay tuned for my monthly OIG Work Plan updates because even in season 5, they continue to drop the second Wednesday of each month. And now it's time for my best practice tips in Trusty Tip. So, in today's compliance tip, I wanted to reinforce some of my documentation tips over the various Trusty Tip segments I have made. I think for those of us in the coding, billing, auditing, and compliance space, I think it's so very valuable to utilize as many trusted resources as possible. And the MACs, the Medicare Administrative Contractors, are an excellent place to start for guidance. So, my MAC here in the state of Illinois for Medicare Part B is NGS, or National Government Services. Now, in my opinion, they have an incredible evaluation and management FAQ section on their website that highlights a slew of questions folks have asked and answers they have provided. But I wanted to hone in tight and focus on documentation. So, someone asked a very good question that I believe I referenced and alluded to in season 1. How long does a provider have to complete a note? When do you consider a note incomplete? Now, NGS's answer is something very similar to what I highlighted way back in season 1. They state that providers are expected to complete service documentation, quote, during or as soon as practicable after it's provided in order to maintain an accurate medical record, end quote. Although CMS does not define a specific time frame, right? They still do not disclose a specific time frame. Now, they also give a citation in CMS Internet Only Manual, the IOM publication 100-04, Medicare Claims Processing Manual, Chapter 12, Section 30.6.1. Now, that is incredible, right? There's no time frame. So obviously it should be completed the day of the date of service. That's always recommended, but always maintain your internal policies as well. If you have internal policy of compliance for when to close a note, when is it considered complete? If that's written somewhere for policy compliance manuals that you've created for your organization, that should be followed. Otherwise, I have always disclosed that 72 hours is a maximum number. 72 hours is what I've disclosed in the past to clients. And once you have that documented in an internal compliance program or your compliance manual and follow that from dates of service to dates of service, that's a very good thing, because you're always supported with the fact that CMS does not, in fact, define a specific time frame, right? So other than during or as soon as practicable after the service is provided in order to maintain an accurate medical record. All right. Now, a note is incomplete, NGS goes on and states, a note is incomplete when it does not support the elements of care represented by the billing code and is not dated and is not signed clearly by the performing provider. Now, I know I've mentioned that in many a trusty tip, right? We have to have a clear, legible signature, electronic or handwritten. And you must always have a date appended to that signature as well for it to be considered complete. Now, they move on and also say, generally speaking, the service should be documented on the same date on which it is performed, since the documentation of date and signature must correlate to the date of service on the submitted claim. So that's really good advice. Now, let's move on. There's another question that someone asked. If there are not two patient identifiers on the medical record documentation when reviewed, will the service be paid? Are there any requirements for patient identifiers? Now, NGS answered, NGS Medical Review will accept one patient identifier on a record, and that will usually be the patient's name and or their Medicare beneficiary identifier number. So also great advice. You should always have the patient's name or their MBI number on each and every page, right? Let me elaborate on their answer. It should be on each and every page of the medical documentation. Now, another question, a third question that someone asked is, how should time be recorded in the medical record? I love this question because I've always stated that start time and stop time should be documented in the documentation. Now, let's see what NGS has to say. Their answer is, although CMS does not define a specific time recording rule, NGS strongly recommends that time spent rendering a service or services is included in the associated notes. The preferred format is, quote, 11 a.m. through 11:45 a.m., end quote. Although, quote, time spent, 45 minutes, end quote, may also be acceptable. So there you go. NGS outlines very clearly that they do prefer, like I do, that you should have a time for starting and a time for stopping. So you should really work with your EHR vendors and figure out how to capture start time and stop time. It's very easy to do on various EHR platforms. I've seen it done. I've helped EHR companies make sure it's done when I'm working with providers. So I always recommend that. Again, in terms of post-payment audits, in terms of look back, you want to protect the medical documentation, right, with that start time and stop time as well. So NGS agrees with what I've always said from episode to episode. Now, another question, I've lost track. I think this is question number 5. So with the EHR, what does NGS give credit for if notes are cloned from one visit to the next? That's a great question. And does NGS look for any specific documentation from the provider in order to give credit for past medical, family, and social history? Now, NGS answers, cloned notes are strongly discouraged, right? Obviously, I always encourage that as well. Do not clone notes. So clone notes are strongly discouraged unless there is clear documentation that the examiner has reviewed the prior material with the patient and updated it as necessary, right? That's always the key feature. If you copy and paste, you need to make an edit, right? Include text that you are reviewing that past information and updating it. Now, NGS continues, when PFSH, past family social history, is copied from a prior visit note, the examiner is obliged to indicate that it has been reviewed with the patient and updated as necessary. Bringing prior verbiage forward into a new note must be medically necessary and pertinent to the encounter. Adding voluminous verbiage from prior visits is usually not medically necessary. Now, I agree with NGS here. I've seen recent audits that I've performed when there is so much copy and paste from prior visits that, as an auditor trying to defend the provider, it becomes very confusing for me, right? Who's trying to help my providers. It's very confusing that they are simply lifting from visit to visits in the past without augmenting, without adding to, editing, revising what they're copying and pasting. So yes, I always recommend in my education that happens after the audit that that type of behavior needs to be augmented with the fact that you are, in fact, reviewing the past visit details for a specific purpose. And they simply did not capture that on the current note that I was auditing. So let's move on. This is another great question. When reviewing documentation, should the diagnosis always be listed in the assessment and plan, or will they allow it to be extracted from the note? Now, NGS has a great answer. For the purpose of clarity, the diagnosis should be listed in the assessment and plan, especially since the number and complexity of diagnoses will be factored into the level of complexity for the visit. The patient's chief complaint may include reference to the diagnosis or may be phrased in the patient's own words as the reason for the visit, but the diagnosis billed on the claim is expected to be clearly stated in the provider's assessment and plan. Now, I completely agree there. Completely agree that there might be some discrepancy as well, right? If you're looking at the HPI, when the patient is talking about their complaint, about their hypothetical quote unquote diagnosis, right, of what they're coming in for and complaining about, there might be discrepancy if the patient is saying that they're feeling okay, they're feeling not so critically ill, but then in the provider's assessment and plan, there's going to be some language that is very, very different there from the patient's own words. So we have to go with what the diagnosis is in the provider's assessment and plan. All right, and then finally, the question is when records are requested for NGS medical review and or appeals, what should be submitted to support reference to information documented at a previous encounter? Now, NGS answers when submitting records for NGS medical review and or appeals in which previously recorded information is referenced, both records must be submitted in order to assess the correct level of coding for the service in question. Now, that's a great answer, right? Because I've seen that happen to practices and billing companies who try and help the provider appeal certain claims. There is neglect on the fact that both sets of medical records and claims don't get sent in when they're trying to appeal for the auditor on the payer side to assess both types of documentation, right? What was actually changed. So here it's very clear that NGS does prefer that both sets of records need to go in, right? So they can then verify and justify that that payment should be upheld or reversed so you can obtain and keep your monies. So I thought those were really, really great questions and answers provided on the NGS website. And they do change these questions and answers from time to time. So if you happen to be in this jurisdiction, I recommend you reviewing this particular website. And don't forget, you can always look at all of the MACs on their web pages for their questions and answers because all of it is applicable to those of us in this healthcare space. It's just a good defense to start looking at trusted resources so you can provide clear guidance to all of your payers from state to state. So I hope you found this particular trusty tip to be helpful because I think a better, smarter approach is definitely one that's proactive and starts by painting a clear, rich, and vibrant medical picture the first time so your certified medical coder can then abstract codes with accuracy. And finally, I focus Season 5 Spark on clarity and focus. I want this 5th season Spark to be filled with the world's thought leaders, writers, artists, philosophers, everyone who inspires the need for clarity and focus in all that we do. So, in this week's inspiring quote in Spark is from comedian Mindy Kaling. If you don't see a clear path for what you want, sometimes you have to make it for yourself. Absolutely true, right? I think this is an amazing quote that reminds us to blaze our own trails if we cannot see what we want. It is our clarity, it is our focus that allows us to see our unique vision has not already been started by another. There is no path to follow, no one in particular to follow. With strength and with purpose, we can create our own path. I am happy Mindy Kaling's spark still burns brightly in all of us today. So that wraps up today's episode. And as always, I appreciate you all diving into today with me. If you want more information from me, please go ahead and follow me on LinkedIn. I'll leave links to everything in the show notes below. Please have an amazing week ahead, and please continue staying safe and healthy. Thank you so much for listening in on today's episode, and I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday.